So let's get into it, guys. Why are data skills important? Uh, Data, as I mentioned, are everywhere. And if we are able to collect, synthesize, and analyze information that will better help us understand public health problems and their solutions, we are stronger as public health professionals. This also allows us to understand and communicate peer-reviewed public health literature for maintaining good public health practice and introducing new practices. We know that the landscape is constantly changing. Public health, medicine, all these different growing fields are constantly evolving. So keeping up to pace on what's going on and having the grips to maneuver that information is extremely valuable, as well as the ability to communicate, to articulate important statistical ideas and trends to colleagues and the public. Very, very valuable. And then to navigate the tools to identify misleading or incomplete information. Unfortunately, the world is rampant with information that is not entirely just or sound on its own. So there's a lot of different things that we can learn to understand misleading information. So I'm going to start by talking about the research question. And I'm going to spend a few minutes on this because a lot of times we have data, maybe you have information from a survey, or you're asking a group of people a series of questions, or maybe you're collecting electronic health records, or you just have information at your disposal. But the first thing that should be done before making any decisions or trying to use your data is to figure out what kinds of questions you're trying to ask. Conceptually, that makes sense, but it's not adopted in practice as universally as it otherwise should be. And it really is the perennial starting point to figure out what's going on. I believe it is the most important component of research. It helps kind of center you, like the dreidel in the movie Inception, to figure out where you are and what your stance is. The research question always brings you back into that central point of your perspective. Features of a good research question always consider the following. Are they relevant? It has to be an issue covered by the research. It has to be manageable within a scope, not too large, not too small. It has to be a specific question, something that can be measurable and actually possible to investigate. It has to be clear and simple. We can't get confusing and ambiguous with which the question is asked. It has to be interesting. Do we even want to know what the answer to this question is? It has to be a legitimate question, not just a statement. Not explore the rates of cardiovascular disease in region 1 of the healthcare planning regions of Montana. That's not a research question. That's a statement. It has to be answerable. You have to have a question that incites an actual response. All of these things are important to consider when establishing a research question. I'm going to go through some examples, as well as examples in my personal life and research, which I'm going to do a lot throughout this talk. But I believe that it's going to give some context and help you all kind of navigate this presentation more. So the research question, it's not just me endorsing its importance. It's a very well-regarded, important, vital piece of the initial stages of research. And there are different frameworks on how to maneuver and establish a research question. Here we have the FINER framework. It's a framework in research that offers structure and guidance for planning methodologies, prioritizing the right questions, and constructing logistical presentation sequences. So a lot of people, especially in a lot of health systems research, will use the FINER research framework. For those of you who are clinicians, work in a hospital setting or a clinic, the PICO question is often used. This is another framework: population, intervention, control, outcome, and time. If any of you have heard that, that's just another iteration of how important it is to establish your research question. Bad research questions incite a lot of subjectivity or ambiguity or unnecessary inquiry. For instance, should abortion be legal? That's not empirically testable. It's not a scientific question. A general topic, treatment of alcohol and drug abuse. That's not an actual question. That's just throwing something into the abyss, throwing spaghetti against the wall and hoping it sticks. There's no actual question attached. Do police affect delinquency? This is a bit vague and not a measurable response. Has the incidence of child abuse risen? In reference to what? Where? How? In what context? We're getting a bit more refined with the question there, but there's still a lot more. Good research questions establish all of those characteristics. Has the incidence of new forms of child abuse appeared in Wisconsin in the past 10 years? That's a good exploratory research question. Are the children raised in impoverished households more likely to have medical, learning, and social emotional adjustment difficulties than children who are not living in poverty? There we have the specifics, the answerability, the measurability, the interest, all the pieces that we need to determine a very pointed research question. Now I'm going to give you all a story for how this has been done in practice. This launched my career as a statistician. When I was a senior in college in a small school in southern Vermont, Castleton, it was a D3 school. I was contacted by the men's basketball coach, which was very strange because I didn't play basketball. I played hockey, but it was weird to just be kind of contacted randomly by a coach. Apparently, he had contacted the math department, and then my advisor kind of sent me over there. So I go into the coach's office, and he's all frantic. He's like, "All right, close the door, close the door." I essentially what was happening was our team, our D3 men's basketball team, had made it to the semifinals of the ECAC regional championship the year before. It was the best that the team had done in over a decade, and everyone was riding a high. Problem is that this team lost 4 of their 5 key starters in the year in the off season. They all graduated. So the coach had a lot of like pressure to do well, but he was worried he wasn't going to. And so this was back in 2012, which is kind of fairly early in the stages of how like uh, statistics, like sports statistics, analytics were used like very regularly. Now, if you turn on a college basketball game or MLB game, if anyone's watching the World Series, there's so many like more granular statistical analyses kind of embedded within the sports. 10 years ago, it wasn't quite what it is now. So he was like saying, I know that I know that people use statistics in sports. I just don't really know how. So maybe this could be a great project for you. And I was like, all right, well, that's cool. Yeah, I'd love to. How about you give me some independent study credits on the dime of the university? He's like, done. That's how you negotiate when you have no social clout as a 22-year-old undergraduate student. And so then I was off. But I was working off of an extremely vague research question. The research question that he said was explore statistics for the Castleton men's basketball team. That is the definition of spaghetti against the wall. That is not a measurable question. That is not an answerable question. That is not a specific question. That's not even really that interesting of a question. So I had a lot of work to do to actually figure out what can be useful for this coach. So then I started thinking, I'm like, all right, well, what kind of data exists in basketball? Well, we got points, we got assists, we got rebounds, steals, free throw percentage, yada, yada, yada. There's a lot of statistics that are captured in sports. Okay, cool. Yeah, I can look at that. I can evaluate, players by that. But I realized that there was more kind of, I needed more. I needed to kind of digest the inquiry a bit longer. So what I did was I actually went to, before the season started, the coach had a scrimmage with a neighboring university. And I was sitting in the gym and I was watching them play, and I noticed that the coach had a very odd substitution method. For those of you familiar with basketball, you have 5 people on the court, and you have a bunch of subs, and then there's whistles very frequently, and occasionally people will get swapped in and out of the game. But this coach did something a bit different. He had a unique substitution method where he actually swapped out all 5 players in and out like every minute. I've never seen this done in basketball, not at the professional or collegial or amateur level. He would take all 5 people, swap them out like every minute to minute, 30 seconds. And he wouldn't do the same 5 people in and out and just kind of rotate them. He did like a random 5 group of people, put them in like you, go. And then you. And you just keep doing that. His rationale was we got fresh legs, defense doesn't know who to cover. I can see the appeal, whatever. In any case, I noticed that because of that unique substitution method, it actually mirrored something that I was more familiar with, having been a hockey player, a line change. For those of you unfamiliar, in hockey, line changes are where you take all 5 players on the ice and swap them in and out very frequently, every minute to minute 30 seconds. That's a standard of practice in hockey. It's not a standard of practice in basketball. But because I noticed that there's a statistic that actually calculates that in hockey. It's called the plus minus statistic, which is a measure that looks at a player's goal differential while they're physically on the ice. Finishing with a +2, for instance, means that by the end of the game, while you were physically on the ice, 2 more goals were scored for your team as compared to the opponent. It has a theoretical range of negative infinity to positive infinity, and it's been used as a key marker of measuring quality of players' contributions to the aggregate game in hockey for decades. So I thought that's a really convenient statistics to use because of how weird this coach does his own substitution method. And that's what I ended up using. Of course, I also adjusted certain pieces of it because in basketball, there's the foul game, whereas one of the few sports where points can be scored, where everyone else is just watching. If a person would foul someone and go to the line to shoot a free throw, they would be individually rewarded or punished as accordingly. Which that's all to give probably a little bit of a more long-winded statement to essentially explain that I went from an old ambiguous research question, which was explore statistics for the men's basketball team, to the new research question. Are there any visible patterns between an individual's plus-minus statistic with the team's plus-minus statistic within the players on the men's basketball team? Y'all notice how from the old research question to the new research question, we take a giant jump up with specificity, with interest, with the ability to answer, measure, and it's relevant. It's tied to some sort of actual answer. And it obviously, to do what I did, to go and sit down and watch and kind of observe the coach and how he has this weird substitution method and, all that piece. There's fluidity with which you kind of navigate to go from a vague research question to a more pointed one. This is just an example of how you can do it in practice and how a little bit of kind of critical exploratory thinking can go a long way from the outset of a project before you actually measure or even get into your data. This is a little figure. I ended up doing some regression analysis that looked at how individuals performed in reference to the team. This is a little figure that I created to show the differential across different results from a team. I won't get into the specifics of the measurement itself, just to show you that there was a lot of quantitative measurement that was done on an individual basis. What it ended up doing, in short, was I would give the coach a lot of advice throughout the season. I would tell him which players to play more and less based on what I was seeing. And it had nothing to do with any of the statistics that were regularly captured in the sport. I would notice that certain players yielded a net neutral value in the game, and their presence was more beneficial if they were projected to do more poorly. And then other players had a more closely tie into the result of the game and contributed more to overall points. So I told the coach the entire season, play number 37 more, play number 23 less. And he took all my advice to a T the entire season without fail. And they ended up making it to the finals of the NCAC championship. And they almost won that year, which is a bummer. If they had won, then this would have been a Cinderella story for me at least. But no, they did better. They did better despite having been projected to do worse. I wrote a little article in the sports column, which was my first, I wouldn't call that a publication, but it was my first little nod. And then this was one of the highlighted statements that I put on my resume moving forward. And then statistics became a way of life. So anyway, that's one example of how the research question is extremely important. So now we're going to get into talking about primary versus secondary data, and then we're going to talk about study designs. So real quick, just a quick nod of the difference between primary and secondary data. Primary data is data that's collected by you directly. It's information that didn't previously exist. You collected it for answering a research question that you propose. This can be done by surveying a group of participants in your community. collecting observational data, conducting interviews or focus groups. There's a lot of different ways you can collect primary data. Secondary data is data that's collected by someone else earlier for a different function. And you can still use secondary data to answer your research questions. You can request data from the Montana DPHHS. I've done that on multiple times, collecting information from the behavioral risk factor surveillance system, hospital discharge data, etc. There's a lot of secondary data sources out there. You can collect data from the census. They have public records at a state and regional level. That's all secondary that you can use. For those of you in hospital systems, electronic health records, anytime you pull EHRs, that's secondary data. Generally speaking, when you collect primary data, you tend to have strengths tied to accuracy and reliability, whereas secondary data, its benefit is accessibility. Now, that's not to say that primary data isn't accessible and secondary data isn't accurate. Generally speaking, depending on what you're trying to do, sometimes resources and time and opportunity might be the contributing factor to why and how you might collect either primary or secondary data. But it's important to know the benefits and pitfalls of both, as well as how you would actually conduct your study, how you would ascertain your data and then pose your research questions. So there's a lot of different study designs that exist out there. A study design is a set of methods and procedures used to collect and analyze data in a study. Once a research question is defined, the next step is to determine what is an appropriate study design. There are many, many different ways to answer a research question. Now, broadly speaking, there are two types of umbrella study designs. We have descriptive studies and we have analytic studies. Descriptive studies traditionally will describe characteristics of a population. It often won't measure anything. Its most common descriptive is case reports or case series. A case report describes an individual's experience, some sort of phenomena. Oftentimes there's a detailed examination on a specific individual, and it's useful if there is a need to obtain in-depth appreciation of an issue, event, or phenomenon. Oftentimes, case reports are conducted when there's little known about an issue or a phenomenon. And then case series are similar, except instead of one individual being examined, there's a collection of individuals. So here I'm going to end up sharing with you a ton of studies that I've done in the past that highlight these examples. And depending on what kinds of research questions you might propose, might kind of tie you into how to maybe or to determine what might be the appropriate study design for you. This first paper is a case study that I published back with an occupational therapist who used to live in Missoula, now lives out of state. Therapeutic positioning to address neuromuscular scoliosis on an adolescent child with Aicardi syndrome. This occupational therapist works for the Montana Postural Care Project. She has designed and implemented a 24-hour postural care intervention to a large number of individuals across the state. Back in, I believe, 2012 or 2013 is when she initially started to do it with this individual. This is just an explanation of one patient, an 11-year-old girl with Aicardi syndrome. It's a more complex neuromuscular scoliosis disease, more rare and more complex than cerebral palsy. The young child was entering adolescence at she was 11, so she was entering adolescence. Her physical growth was going to be the most in her entire life. So with the curvature of her spine, with her chest ratio, with her depth width being unaligned, it was a vital and opportunistic time to implement an intervention that might improve these patient-centered outcomes, specifically with physical functioning, with quality of sleep, and with these ratio measurements. So essentially, that's what the occupational therapist did, and then followed her over the course of looks like 6 years. So from June of 2012 to June of 2018, regular measurements were taken to observe the chest symmetry and the depth width ratio of this individual. And we found that after about a year, this individual ended up getting an ideal chest width ratio and having it sustained for the next several years thereafter. And now into her adulthood, it persists. So there's no statistical analysis, there's no research question. This is a descriptive study that's simply describing a phenomenon, something that works, something that can be contextual for follow-up research. An example of a case series. Here it's not one of my papers, but it's a great example. It's clinical presentation of COVID-19, a case series and a review of the literature. Text is a little bit small on the screen here. My apologies. So this article was created to address physicians caring for patients with COVID in their clinical practice. The intent of the paper was to identify the subjects in whom the infection is most likely to evolve and the best methods for management in the early phase of infection, and determining which patients should be hospitalized and which should be monitored at home. So this paper, if you can see closely around the circle point, this paper was published in June of 2020. Do y'all remember back in June 2020 how little we knew about COVID, how the lockdown happened a few months previous? There was a lot of question marks. There was a lot of information kind of puttering around. This paper, in a very timely fashion, described the characteristics, the clinical presentation of 40 patients that had been admitted to hospitals, and explained how they were treated and the experience that both physicians and patients had. Having it being published in June of 2020 was extremely helpful for maneuvering treatment for particularly high ailment issues with respect to COVID. Again, no statistical analyses per se, but a description of a phenomena, in this case, COVID. Now we have analytic studies. Analytic studies, unlike descriptive, attempt to quantify a relationship or association between two variables, usually one exposure and one outcome. And then within analytic studies, you frequently will have either observational or experimental. Observational studies are conducted without any intervention or experiment or treatment. There's no manipulation of the data. Oftentimes in social science, we are limited to observational research. You can't force this group to smoke cigarettes and this group to not. Oftentimes for health risk behaviors, observational studies are the best that we can do, which contrasts to experimental studies in which researchers introduce an intervention and study its effects. You give this group drug A, and then you give this group the placebo. That is an example of an experiment because you are manipulating the characteristics of what each participant is exposed to. Oftentimes, the term randomization is associated with an experimental study design. So back to observational real quick. There's three main observational studies that are important for any public health professional to know. The first is a cross-sectional study. Cross-sectional studies involve looking at data from a population at one specific point in time. There's no follow-up. It allows one to calculate the frequency of a disease, or rather the prevalence of a disease, or the frequency of some sort of risk factor. There's a lot of advantages to cross-sectional studies. It's pretty quick and inexpensive. It's easy to conduct. There are no ethical challenges, usually. Data on variables are all collected at one point in time, so you can look at multiple exposures and outcomes. And it's helpful for establishing preliminary evidence for future studies. I have a great example of cross-sectional studies that I'll get to a little further on. Of course, every study design will have disadvantages as well. For cross-sectional studies, it is impossible to make a causal inference. We can't definitively say that the exposure caused the outcome because the information was captured at the same point in time. We can't necessarily identify temporality, what came first, as well as all the other things that are attached to causality, which we'll get to in a moment. We're unable to, it's not good for studying rare outcomes as well. A couple cross-sectional studies. On the right, I share one of my papers. On the left, I share one of my colleagues, Dr. Juthika Thatcher, who recently got her PhD at the University of Montana. On the left, you can see that Jessica published a paper on nurses' perceptions, experiences, and practices regarding the HPV vaccination, results from a cross-sectional survey in Montana. It conducted a descriptive study to determine, or a descriptive cross-sectional study to determine nurses' perceptions, experiences, and practices regarding HPV all across Montana. The paper to the right was my study, Barriers to Healthcare Access Among U.S. Adults with Mental Health Challenges, a population-based. This study was used to quantify the prevalence of barriers to healthcare access among U.S. adults with and without mental health challenges, and evaluate the relationship between mental health and certain barriers to care. I collected information from the National Health Interview Survey, which is a survey that is administered by the Center for Disease Control and Prevention. Can anyone tell me, between these two papers, which study collected primary data and which collected secondary data? Whoever can write in the chat. So the paper on the left is 1. Paper on the right is 2. Which one collected primary? Which one collected secondary? Beautiful. Exactly. This left paper, nurses' perceptions on the HPV virus or HPV vaccination, primary data. That was information that was collected specifically for that study. I collected information from the National Health Interview Survey, which is a national survey that is administered every year to like 30,000 households across the country, and it was not specifically used for my study. National Health Interview Survey, among many other national surveys, are used for thousands of different things. That data already existed, and I used it to ask my research questions. As public health professionals, you have options of either collecting your own data or collecting data that already exist. There's a lot of flexibility across those different options. Keep clicking away, and then I try to click and it's not working. Okay, we're good. Now we're going to talk a little bit about cohort studies. Cohort studies involve looking at data that follow participants over a period of time, longitudinally. Participants typically share some sort of common characteristic. Cohort studies can be both prospective or retrospective. You can follow patients from this point in time onward, or you can look at historical records that track patients over a period of time based on a period of time that already happened. So you can look prospectively or retrospectively. Retrospective cohort studies involve analyzing a group of people who already have been collected, a look backwards. The advantages for cohort studies are that they are effective and robust, and helpful for potentially establishing cause and effect. Because you're looking at things longitudinally, you have more of an ability to determine a temporal relationship. And you can also examine multiple effects of a single exposure. Of course, study designs don't come without their drawbacks. Cohort studies are no exception. For disadvantages, you may have to follow people for a long period of time. For instance, if you're looking at a group of people in their 20s to look at the likelihood of developing chronic disease or mortality, I mean, you would have to follow up individuals for many, many years to identify any of the outcomes that you're looking for. They could also be potentially expensive and time consuming, and not good for studying rare outcomes, not good for studying diseases with a long latency. There's a cohort that I can share. This was a study that I had worked on with the psychiatric unit at Billings Clinic several years ago. It was a prospective open trial of adjunctive triple chronotherapy for acute treatment of depression. We administered this adjunctive treatment, which was a simultaneous employment of a therapeutic manipulation of sleep-wake cycles with bright light therapy on a sample of adolescent patients with very pressing acute mental health issues. And as we can see here on the left, those figures show measures of depression, the aggregate measures of depression over time. The intervention was a 4-day inpatient stay, and we tracked their depression every day. We also followed it up about a month after they were discharged. So that was a prospective study because we captured information over a period of time. We also found that the intervention showed an extremely strong signal, which has since incited more rigorous, causally linked follow-up trials, randomized trials. I believe Billings Clinic is in the process of finishing a randomized clinical trial of this intervention now. Another one that we just finished, another study through Billings Clinic. I linked up with the neurology team back earlier this year, last year, about a year ago. We looked at the use of holographic memory resolution to improve the physical and biopsychosocial symptoms of chronic pain. This intervention took a sample of folks that were administered in the neurology lab, and we gave them this intervention. By the way, I'm a big component of alternative therapies that negate means of unnecessary pharmacological means of treatment in the United States. The whole overprescribe, undertreat kind of thing is something that resonates very passionately with me. So there's oftentimes a lot of different treatments that I'm going off on a tangent here. But anyhow, these kinds of interventions are really interesting to me, and they often allow for a prospective examination, a prospective cohort study. So here we see the same kind of figures. We looked over a course of 4 study sessions by administering this intervention. Holographic memory resolution is a mind-based therapy that's been used for decades as a non-pharmacological intervention for trauma imprinting. So patients had 4 sessions over the course of several weeks. We have session 1, 2, 3, 4 in those figures, and we looked at their depression, anxiety levels over a period of time. Another example of a cohort study. Finally, we have a case control study. Case control studies involve looking at data by comparing 2 groups, one with an exposure or disease of interest, and another group without the exposure or disease of interest. It's always retrospective. You're always pulling from information back in time. And this allows you to examine the odds of having a risk factor or an exposure if an individual has a specific disease. So it's a very clear temporal examination between a specific exposure and a specific outcome. It's effective for measuring rare diseases or diseases with a long latency period because you're controlling for the need to follow up patients like you would in a cohort. They tend to be they're less costly, they're less time consuming. They're useful when exposure data are expensive or hard to obtain. And they're useful for when studying populations where follow-up is difficult. For those of you who have tried to collect information at any given point in your careers, you can probably attest to the fact that not every question, not every piece of information that you want to collect on patients or communities or anyone in general is easy to collect. There's often a lot of hurdles with that. However, there's a lot of potential bias in this study design. There's potential observational bias, and it's not always effective for measuring rare exposures. I have another example of a case control study. I worked at Billings Clinic for 2 years, so a lot of these papers are clinical research. Some of them are health systems. I try to pepper in a lot so you all can see different kinds of studies across different fields. This was a study of looking at predictors of oversedation in hospitalized patients. This was a case control study where we collected information on a sample of patients that had gone through surgery at Billings Clinic. Excuse me. The objective was to determine characteristics that were predictive of oversedation. So people that went through surgery either were or were not oversedated, and then we looked at characteristics that then identified what linked to them being oversedated. So it was retrospective. We pulled the information. It was secondary, so it already had existed. And then we were able to find that there were certain characteristics that increased or decreased the likelihood of a patient becoming oversedated. We found that women, female sex, had about a 2.4 times increased odds of being oversedated compared to men. People with untreated sleep apnea were over 30 times more likely to get oversedated. Patients with comorbid renal disease were over 4 times more likely. However, people with as-needed use of oral opioid treatment were significantly less likely, with an odds ratio below 1. So this kind of research question is helpful for, or questions to try to identify factors associated with something. A case control study can often suss that out with some pretty strong rigor. Now, we mentioned causal inference. We kind of suggested it throughout. So how do we establish, for example, that smoking causes lung cancer in humans? A strong case for cause and effect can still be made, but it takes some work. The conclusion from the US Surgeon General in 1964 that smoking causes lung cancer was based on a number of factors. First, previous research had established the consistency of the association across many studies, both prospective and retrospective. Consistently, there was a strong association between smoking and lung cancer. The existence of a dose-response relationship. Studies would ask how much people smoke. Pack a day, pack every 2 days, how long have they been smoking in their lives? And then that is a measure of dose that then is tied to looking at the incidence or the prevalence of lung cancer later in life. So certain studies ask that question, as well as making sure that they could determine the temporality, looking at the exposure of smoking, and then later on, prospectively, to see when and in what capacity lung cancer might have manifested. Looking at controlled experiments with animals as well. A lot of times, a lot of health systems and clinical research will use animals to serve as a proxy for randomized trials that can otherwise not be performed in humans. And of course, we consider the biomechanism, the biochemical and the biological imperatives of whether or not it makes sense for smoking to cause lung cancer. So this is just one example. This is kind of like the best public health example of how causality can be achieved just with a lot of legwork, especially for something like smoking and lung cancer, when you can't just randomize one group to get to smoke and another group to not. Smoking, or the prevalence of smoking as a result has decreased over time. It's been going up actually more recently because of all the different modalities with which people can smoke. But the prevalence of smoking in the United States was over 50% back in the 40s and 50s. People were smoking on airplanes and in restaurants very regularly. It was embedded in our advertisements as kind of like a societal means of acceptance. But then in conducting all this work and examining all these different domains on the risk of the relationship with it in lung cancer, then caused inadvertent policy change, no longer being able to smoke on airplanes, all this developmental work that then kind of shifted the public perception, and as a result, the overall prevalence of smoking. By the 90s, I believe the prevalence of smoking in the United States was around 20%. Don't quote me on those exact numbers, but I know that it had a substantial decrease over time. The last study to note is experimental studies. These are often randomized, meaning subjects are grouped by chance into one group or the other. The term randomized control trial, RCT, is often used for experimental studies. It's where you have eligible people randomly assigned to one of two or more groups. One group receives the intervention, while the control group receives nothing, or a placebo. And then the researchers then study what happens to the people in each group. The advantages of an experimental study is that it has a high level of control of variables. Because you can randomize people to one or other group, it's easier to comment on cause and effect and provide specific measured conclusions. It's also easy to replicate in different populations and can be combined with other research methods. However, there's issue of human error. They are very time consuming and expensive, and there may be ethical or practical problems with the actual intervention itself. Like I mentioned before, we can't just give one randomized group cigarettes and tell them to smoke them. That is an ethical issue. So experimental studies are not always feasible to do. Here's an example of an RCT of convalescent plasma in COVID-19 severe pneumonia. Again, fairly early on in the COVID pandemic. This was a randomized control trial done in, I believe it's researchers out of Buenos Aires in Argentina. They randomly assigned hospitalized patients with severe COVID-19 pneumonia to either receive convalescent plasma or a placebo. And they were looking at the patient's clinical status 30 days after that intervention to look at mortality and other patient-centered health outcomes. They didn't find that there was any substantial difference, which is why convalescent plasma did not gain any traction to become any means of treatment modality for patients with COVID. But it was this randomized trial that essentially tested that intervention, among others. This is just one example. So study designs, I'm sure at some point, some of you may have seen like the hierarchy, the pyramid of how some some study designs are stronger than others. Early principles of evidence-based medicine indicate that a hierarchy does exist. Various versions of this pyramid have been described. All of them tend to focus on weaker study designs in the bottom, like case series, case studies, followed by case control studies, cohort studies, then followed by RCTs. Then at the top, we have systematic reviews and meta-analyses. Systematic reviews and meta-analyses are essentially doing several studies at once, either in kind of a synthesized literature review or combining the results of different studies. But one of the things that should give all of us solace in the public health sector is that it's not, the model doesn't actually look like A. It looks more like B or C. There's a lot of fluidity of the scientific rigor of different study designs. The strengths and weaknesses of a study design should be seen in light of the research question. You can't always do a randomized clinical trial, and that's okay. You want to ask the right question the right way and conduct the study design that is most suitable for the research question. If you force the means of another study design when it's not necessarily the most feasible or appropriate, that's not going to yield you a better outcome. You want to find what fits. It's like when you're picking out clothes. You want to find the right fit. For example, it would be unethical to design a for example, it would be unethical to design a randomized control trial deliberately exposing workers to a potentially harmful situation. If a health problem is a rare condition, a case control, which begins with the existing cases, may be the most effective or efficient way to identify the potential causes. Or if little is known about a problem, a cohort may be the best to look at it, how it manifests over a period of time. That's just one simple baseline example. But out of all the questions that I know you have all percolated with in your professional lives, I think you should gain solace in realizing that the right study design is not necessarily arbitrarily, does it have to be at the top of the pyramid. The last study design I want to mention are qualitative studies, which are pretty much separate from everything else that we talked about. Qualitative studies are a type of research that explore and provide deeper insights into real-world problems. Instead of collecting numerical data through a descriptive or analytical design, qualitative studies help generate hypotheses to research questions that aren't fully fleshed out yet. It enables deeper understandings of patient experiences, phenomena, and context. It allows a researcher to ask questions that aren't necessarily quantifiable. This is another study that I did when I was at UM. It was a qualitative study of rural healthcare providers' views of social, cultural, and programmatic barriers to healthcare access. My entire dissertation essentially broke down the fact that access to healthcare is very multi-layered. Not only is it linked to things that are very much quantifiable, like affordability or availability or approachability, but there's a lot of social, cultural, and logistical issues that you can't necessarily ask on a survey. So I sampled a group of healthcare providers across the state of Montana, and I asked them questions that were based on qualitative interviews, asking them their views on these kinds of like less quantifiable characteristics. And I ended up finding that there were specific facilitating and debilitating characteristics that the providers consistently mentioned as part of things that help or hurt their patient populations. There was no, these kinds of data were qualitative data. It was an exploration of depth rather than breadth. So if you in your guys' professional lives are curious about what questions you even want to ask, maybe you don't know the right pointed research question to ask, maybe a qualitative study can help flesh that out a little bit more. Maybe you take a group of people that you know might kind of help provide context for establishing that research question, and you just ask them a series of open-ended questions on what their views are. There's a lot of science in and around this process as well, and it's a valid means of determining context for some sort of issue. Talk about community assessment for public health emergency response, CASPR. The last time we gave this data training, there were a few folks that specifically asked about this, and we realized that it's a very necessary component to include, especially for many of you in the public health sector working with your respective health departments. So first off, a CASPR is a type of rapid needs assessment that provides household level information to public health leaders and emergency managers. The information generated on a CASPR can be used to initiate public health action, identify information gaps, facilitate disaster planning, response, and recovery activities, to figure out the allocation of resources, or assess new or changing needs in the community. A lot of different ways a CASPR can be used. It will take a cross-sectional study design, so just information captured at one point. And the methodology is pretty sound. They use what has been used on the expanded program on immunization to estimate vaccine coverage in Africa. So the methodology of it is pretty strong. So CASPRs are designed to provide public health leaders and emergency managers information about a community so they can make informed decisions. Just like many other cross-sectional studies, it's fairly quick, inexpensive, flexible, and pretty simple. It can be used in either a disaster or non-disaster settings. It can influence public health in a myriad of ways. It can assess public health perceptions, estimate the needs of a community, assist in planning for emergency response, or, as many of you might have relevance for, it can serve as part of the public health accreditation process. There have been hundreds of CASPRs implemented in the US over the last 20 years. This is a graph that shows the distribution of CASPRs across US states since, I believe, 2001. We see in Montana that we've actually administered a handful. So as I mentioned, CASPRs can be used for a number of different reasons. Back in 2008, there was some severe flooding in Linn and Johnson County in Iowa, and they conducted a CASPR. In the wake of all the devastation from Hurricane Sandy, Suffolk County, New York, conducted a CASPR. Of course, some of you may recall all the drought that's been persisting in California for the last decade or so. Mariposa County conducted their own CASPR addressing California drought. Some of you may remember Navajo Nation down in Colorado had this very dangerous mine spill at the Gold King mine. So that a CASPR was conducted for that. And about a year later, the Zika virus appeared in Texas in Williamson County, and a CASPR was conducted for that as well. In Montana, there have been 6 counties in the last 15 years or so that have conducted their own CASPR: Hill County, Madison, Mineral Valley, Richland, and Dawson, as per the standard application with the CDC. These were all done for a generalized community health needs assessment, not disaster response. Excuse me. There's a lot of resources online for facilitating or for conducting a CASPR. There's a lot of tools that they provide. A little bit of history real quick. In the early 2000s, the two-stage cluster method became an increasingly widespread method for disaster response in the United States. The CDC developed this Casper toolkit to outline and standardize the assessment methodology. Excuse me. As part of this process, the CDC coined the term Casper to distinguish it from other rapid needs assessments. Now, after this section, I'm going to share with you an actual assessment that I conducted, which is very comparable to the Casper in the state of Montana. But they use the term Casper to kind of coin their own process. The Casper Toolkit provides guidelines to assist personnel from any federal, state, tribal, local, or territorial public health department or other emergency response agencies. It provides step-by-step guidelines for preparing a checklist, developing your questionnaire, doing your sample selection, any necessary training for public health personnel, the methods of data collection, then analysis, then report writing, and then they provide a lot of templates and examples on top of that. How are data used? Data are used from Caspers to provide situational awareness, to confirm or contradict rumors, anecdotal reports, to identify and provide estimates of needs in the community, to establish priorities, and tailor interventions and communication messaging. Other benefits to incite the needs of changing the community, monitoring the changes of community needs, raising visibility of emergency management and public health in the community, to justify requests for outside assistance or funding, evaluating the effectiveness of response activities, and serving as field exercises to build capacity to strengthen the public health workforce, particularly for emergency situations. In considering whether or not your county, your local health department is considering doing a Casper, you should decide if Casper provides an appropriate sampling methodology based on your objectives, timeline, and available resources. A lot of times, oftentimes, whenever we have data or whenever we're trying to collect data, we have to consider, the who, what, when, where, why kind of thing. And the resources that often are limited in our local capacities is always a factor to consider. Casper uses, as I mentioned, a two-stage cluster design in which 30 clusters are selected proportional to the number of households, and then several households are systematically selected to try to create as much of a generalizable response in your community. A clear understanding of how Casper information will be used, who the relevant stakeholders are, and needed available resources is important prior to moving forward with your Casper. The example that I'm going to give here in a moment is going to highlight the importance of doing your due diligence up front. Caspers will generally be descriptive of an entire sampling frame. It does not provide information on subpopulations or target specific groups, meaning that you wouldn't necessarily want to use the CDC if you're trying to ask a specific research question for a specific group. Using federal government resources are better when you're trying to examine characteristics in the aggregate. If you're interested in looking at people with chronic illness or issues with homelessness, or pregnant women, or a specific phenomenon of interest, a Casper may not be the right approach. The CDC has an open portal and email to field any questions and provide support. There's also modules that oftentimes people will be given a credential basis on. So the CDC has those resources as well. This one is for disaster epidemiology. There are, I believe, a handful of other training resources that are provided by the CDC. Traditionally, Casper will take 4 phases: preparation, implementation, and then the evaluation, and then reporting of the information. Preparing for a Casper, you generally will work with leadership, key stakeholders, and Casper subject matter experts within your state or the CDC to help and prepare. Then when you actually implement the Casper, you'll conduct face-to-face interviews in the field. The advantages of that being face-to-face include a higher response rate, connecting to the community, and increasing visibility and trust in the health department. I know that for many of you, that's probably been a lingering challenge in your professions. Public health, fortunately, now is more of a mainstay term that wasn't as well known or understood. I mean, granted, it's not fully understood now, but it's a more understood term now than it was 5 years ago. I guess the pandemic had, some benefit to exposure of that. That's not to say that the pandemic was good, just as a context for the exposure of the term of mental health. Um, but of course, there's lingering challenges with trust and positive regard with health departments and communities, particularly rural communities. I've worked I've worked with rural communities in the state, and I can anecdotally attest to that very phenomenon. We know that that exists in the literature as well. The whole concept of rugged individualism, the do-it-yourself, the pull yourself up by your bootstraps, the I don't need help from anyone kind of thing. These are all things that make our work much more challenging, especially in rural health areas. The interview teams can also provide anecdotal information that can help guide response and recovery efforts. So when you're collecting the information, when you're collecting this primary data, oftentimes you can kind of learn as you go. You can figure out what's working, what's not working, what you might want to adjust for future. And then when you have your data, you will be able to utilize statistical software that allows you to organize the data. The software that the CDC provides is user friendly and does not require computer permissions or download, and is free of charge. So any of the software needs can be met free by federal government agencies. And then there's tutorials and guidance for all of that, as well as means of how to disseminate findings. I'm going to skip over this break here and jump right into sharing with you our real-world community needs assessments, which is very synonymous to the CASPR, except I did it with a private research company with me and one other scientist, and we did something that was very similar to everything I just mentioned. Okay, here we go. The Carbon County Health Department. For those of you who don't know, Carbon County is the county directly south of Yellowstone. It's where the county seat is Red Lodge. It is going over the Beartooth Pass, the east entrance into Yellowstone. Beautiful county. Carbon County has been affected by a lot of overlapping health challenges in the last few years. Obviously, there's been COVID, the increased prevalence of wildfires across the western United States, but Carbon County also had a lot of flooding back in early 2022. Last year, actually giving this talk at the Summer Institute back in the summer of 2022, then it was in person. I ended up connecting with Carbon County Health Department officials at that conference. And we linked up to conduct this assessment. My private research company, Piedmont Research, and the Carbon County Health Department. And as I mentioned before, Carbon County there was a trifecta of environmental and epidemiological health challenges that were overlapping in an uncharacteristically hardened way. I know many of you have probably had seen on the news in the last year the magnitude of the flooding that existed. So coupling that with the wildfires, coupling that with the pandemic, Carbon County Health Department was in a world of hurt, and there was a lot of concern. So my research team employed a 4-stage approach that looks very, very similar to the CASPR, the community or the community assessment administered or guidelined by the CDC. We first employed the first stage being a community information consolidation. This was a pre-planning stage, which was the objective of which was to consolidate all up-to-date information that currently exists on the residents of Carbon County to identify the gaps of interest. First and foremost, for all of you, this is the best thing you could do straight away. Don't work from scratch. Figure out what information you currently have at your disposal. I know a lot of us are in smaller healthcare systems, um, smaller health departments, perhaps, but most often there's information that we can use, whether it be in our communities or perhaps at the state level with Montana DPHHS, um, or even at the federal level. There's often information in some capacity that can contextualize the gaps that you're trying to pursue. And it's always helpful to take a little bit of extra legwork to make sure you know what sources of information exist. If you don't use them, then it's just you're leaving money on the table. You're leaving opportunity on the table that would otherwise help you in your quest. For us, we took information from 4 data sources, all had a specific relevancy in what we were trying to examine. The first was the 2020 census, getting up-to-date information on the demographic population of the area. We were able to collect information on a community health needs assessment that had been done out of Beartooth Billings Clinic in 2022. So right several months before we started this process. There was also the 2022 housing assessment conducted by the Red Lodge Area Community Foundation, a nonprofit organization that operates out of Red Lodge, as well as a statewide assessment from Area 2 Aging. Area 2 Agency on Aging was the community assessment for older adults back in 2022. So these were all timely data sources that all had been acquired since the pandemic, and they all casting a light around the room. Obviously, we want to light the whole room, but it was very valuable to have current up-to-date demographic records, as well as gleaning the needs of the community nestled within a subset of the population. Some of you may think, well, why would you want to conduct another needs assessment if there was already one done? The one at Beartooth Billings Clinic was helpful, but it asked a lot of clinical, medically focused questions, and they were only given to people who are actually utilizing healthcare services. One of the first things that the Carbon County Health Department officials told me when I met with them at this annual meeting was that they wanted to conduct a needs assessment to get a pulse on the hard to reach people in the community. I know that a lot of you probably are privy to the fact that, internet connections are not consistent across the entire state. Being able to reach the farmers and the ranchers and the people who won't necessarily use the online survey or won't really have any exposure to it. It's harder to reach people. It's really hard to get a generalizable sample that is truly generalizable of a population. And the counties in Montana, the whole state is huge, but counties are very large. It's not easy to get everyone represented. That was the goal of this needs assessment by the health department. So using information that was gleaned from the Beartooth Billings Clinic assessment was helpful, but that's just one nugget. We want to get the people that aren't using the county's largest hospital. And if a person's not using hospital services or healthcare services, they're never going to be captured in that assessment. The online assessment that was given by the Red Lodge Area Community Foundation was also helpful. That was given to random households across the state, asking about housing issues, meeting housing needs. Fun fact, Red Lodge and the surrounding area is susceptible right now to the temporary housing market, kind of squeezing people out, very similar to how we've seen like Jackson or Keystone or Vail, and a lot of other destination like skiing towns in the Western US. Red Lodge is susceptible to a lot of those issues as well. So we got Airbnb, Vrbo, temporary housing that is kind of like putting a bind with the locals who have been there for 30 years. That's why that assessment was initially done. And it had a lot of interesting measurable response when it came to people's frustrations in and around housing needs. And then the last assessment was done at the statewide level. And it was a random house. It was a survey that was given to random households with at least one member age 55 or older. And this was asking the older adults issues pertaining to their needs being met. Transportation, community, healthcare resource needs that were specific for older adults. So as you can see that all these assessments were they're all very different, but they were all helpful to consolidate what we currently knew about Red Lodge. I went through and tried to collect raw data so I can make sure I had as much refined information across the county as I could. And I was able to get raw data from I believe two out of these three or three out of these four data sources. So again, just all the legwork that's done in the pre-planning stage to then give a little bit of context. And it looks a little bit like this. the This was information pulled from the census. So we were able to get population estimates, age, sex, race, distributions, all good stuff. And then we have information from the housing assessment. It was important to know when it was done and who was actually collected on it. This was just a random sample of households in Carbon County. There were 331 participants in total, most of whom reside in the county seat in Red Lodge. No surprise there. They asked questions about annual income, where they perceive the greatest needs of the community are, and if people believe that there's a high cost of living. I geocoded the information across different counties, or not different counties, different towns within the county. So here we got Bear Creek versus Belfry, among everywhere else. We were able to break down information across all the different towns, whether they be unincorporated communities or physical towns. Bear Creek, Belfry, Boyd, Bridger, Edgar, Fromberg, Joliet, etc. It's not that much. It's not a dense amount of information, but it's something for us to work off of, and that's the important piece. Again, consolidating all the information that you currently have at your disposal. There was a lot of qualitative information that was gleaned from the assessment as well. Remember how qualitative study designs will ask questions about just open-ended an exploration of depth rather than breadth. And then the term mixed methods, for those of you familiar, are assessments or study designs that incorporate both quantitative and qualitative methods. So you can conduct a cross-sectional survey like this that asks about questions like, hey, do you feel that cost of living is high, very high, okay, fine? You can ask a question like that and measure it. And you can also ask questions about, hey, tell me about how you feel about the temporary housing market. Just let people go. And yes, there's always going to be a lot of very colorful language that is attached to that information. That information could certainly be helpful to include on a survey. So the open-ended questions have value unto themselves. Of course, the means of measuring them are going to be different from measuring a quantitatively charged item, but that's okay. You can do both. And here, yeah, so a couple comments. We got, I've lived in communities where this has been virtually destroyed, the makeup of a city like Red Lodge. Stop allowing so many damn Airbnbs. When I first moved here 5 years ago, I could rent a house for $500 a month, yada, yada, yada. I won't get too deep into the language here, but this is information that kind of contextualizes the data from the survey. So open-ended questions can certainly be valuable. That was mostly what was captured from the housing assessment. The community assessment for older adults was conducted between March and August of 2022. And again, as I mentioned before, it was a random sample of households in Montana with at least one member of that household over 55. And a lot of questions here asked if the older adults feel that community is a good place to live. They like their community. They have a sense of community and overall quality of life. They asked economic and transportation focused questions, whether there were resources in the community for proper infrastructure, proper natural environment, good parks and recreation. And then I sussed this information out to try to get a pulse on if there were any glaring issues observed at the state level from the eyes of older adults. We asked, or the assessment asked about affordable quality mental health care, preventive health services, recreational opportunities, fitness opportunities, etc. And we found that there were certain items that at the state level yielded more positive response than others. Healthcare utilization questions as well in the last year. How much time do you spend as a patient in a hospital, in a long-term care facility? How many times have you fallen or injured yourself? Questions like this to kind of get a pulse on the estimated prevalence of hospital usage among older adults. Of course, not ultimately generalizable to the whole state, but information that could kind of point us in the right direction with our needs assessment. I haven't even gotten to what we did with our assessment. This is all precursor work. And then the Beartooth Billings Clinic assessment was done early 2022 as well, right as we were coming on board with the Carbon County Health Department. And they had a lot of information that was actually collected from 3 different assessments over the last decade. One done in 2013, one done in 2019, and then the other one done just recently in 2022. This assessment asked, again, a lot of medically clinical charge questions. People rating their community health, their personal health, their own personal health concerns, as it spans from alcohol, substance abuse, to cancer, to mental health, all the way to stroke, hunger, depression, suicide, domestic violence, etc. As well as reasons for delaying medical care, excuse me, whether it spans to cost-related or wait time, availability issues, insurance, any relationship issues within the hospital setting, not liking doctors, being too afraid or nervous, no childcare, language barrier, the whole gambit. A lot of clinically charged questions. Now, again, this information is very helpful, but remember, this community health needs assessment was done out of Beartooth Billings Clinic and was done within the context of people who are utilizing hospital services. That is contrast to the objective of our assessment of trying to reach as many people in the community as possible, not just people that are utilizing healthcare services, but people that reside in Carbon County. Those populations are not the same thing. A lot more here. They asked about social isolation and stress. We then summarized in our consolidation stage that across Montana, older adults have concerns regarding transportation, housing costs, affordability and availability of healthcare, connection and engagement with their community. Within Carbon County specifically, people generally regard Red Lodge, Joliet, Bridger, and Bear Creek as the areas with the greatest overall need from the housing assessment. Perceived cost of living, housing, and need for housing are all prevalent in about 80% of folks who live in Red Lodge, among those who respond to the survey. Health needs of the community center are mostly centered around mental and behavioral health, access to healthcare services, and chronic disease management and prevention. That was a culmination of the most pressing things that we observed across these different surveys. A powerful quote that helped us contextualize entering into the second stage. We know how difficult it can be. We'd love something like a local employment survey to get a clearer idea of the wages in the area, what renters consider affordable or accessible, etc. I answered this survey to illustrate that only people in our family's position are able to live comfortably in Red Lodge. So many of my friends are housing unstable, and it will cause us to lose a large number of employable people if we cannot find a way to remedy this. These were powerful quotes that really kind of like marked within the some context as to why the local health department would even want to conduct an assessment like this. Quotes can sometimes kind of emphasize the points that you're trying to make, and they can be really powerful if applied properly. So then that was again all before we asked a single question to anyone. Notice how there was a lot that went into that. We essentially did the legwork to figure out like what information exists. That information can be extremely valuable. And again, doing some legwork in that first stage, as the CDC Casper also says, is an important piece to do. Any information that you currently have, never reinvent the wheel. And with most of the questions that you would ever want to ask, there is some information that exists to help frame your approach. Oh, okay. So the second stage. Actually, let me just give a shameless plug here. I give it at the end, but I'll say it here too. If anyone ever wants any data assistance from a public health scientist statistician who lives in Montana, who is as passionate about addressing population health disparities as all of you are, use me. Honestly, if you're listening to this talk and you're thinking, I want to kind of incorporate some of this, I want to ask, I want to do a survey, I want to do a project, I have this data, I'm a little bit, I don't really know the right approach. I have my contact information. I'll make sure it's shared with everyone in following the survey. Please use me as a resource. I'm very much eager to facilitate and empower each of you in your respective health systems. The project that I'm explaining right now came from doing this exact talk a year ago with random people in the crowd who then contacted me. And then this whole project then launched as a result. So anyway, that's my shameless plug. Okay, stage 2, the development of the needs assessments. This served as the planning stage, where we used the information that was gathered in the first stage and then combined it with some key informant interviews to then build the actual survey. Now, one of the things that we did was, again, these key informant interviews. Oftentimes, you want to not bring your own imperialistic assumptions into the mix. Now, you guys doing this in your own communities, you have a better, more comprehensive means of expertise in the perceptions of your community, measurably more so than me, who, yes, I live in Montana, but I'm from Jersey. I'm not a Montanan, and trying to suggest that I know the issues of people in Red Lodge, people in Belfry that had their house washed away, I shouldn't make any assumptions. And even though I live in Billings, I'm still very much an outsider. So we had many interviews very much like this to kind of frame our approach.
If we're supposed to have audio, I'm not hearing anything.
I'm not either.
Oh, my apologies. Never mind then. This audio will not work. Do you all see the Zoom call we have here, at least? Or is nothing? It's all black. Yeah, okay.
We can see apologies. We know you're talking. We just can't hear what you're saying.
Gotcha. Thank you for this is individuals, our research team, members of the Carbon County Health Department, and community-led experts who have lived in the region for a long stretch of time. So myself and my colleague with my research team, this is a member of the Carbon County Health Department and a member of the community who's lived in Red Lodge for the last 30 years. This is an example of bringing people together before or as we're in the process of developing the questions we need. So it's an extra gut check to make sure that you're not missing anything on the perspectives of the community. Oops. Okay, so now there was a lot of information that was collected. We had done several key informant interviews. We ended up designing the survey, having a hard copy. We set it up for both online and physical use. This is what it kind of looked like in the end, the first page of it. And then the actual implementation of the needs assessment itself. This was the fun part. This is where you're collecting your data. We went out all across the community. My research colleague and I, we came into Red Lodge, we stayed there for a few days, and we went out into the communities physically. This was part of members of our team standing outside of a grocery store. I believe that's I want to say that's in Joliet, or maybe Roberts. Roberts, I believe. We spent 3 days all around Red Lodge, Joliet, Bridger, and Roberts, so people could see the needs assessment. The CDC kind of suggests the same piece as well. The way that you increase positive perception of public health endorsement, promotion, and work in the community is to be present. Obviously, that's not going to fix everything, but the more face time, the more presence that you have, generally it will yield a positive result. Here we had tables, we were tabling all set up. We had our QR code, if you all can see that close. The physical copy of the survey could be mailed in with a return check that we provided everyone, but as well as clicking the QR code on your phone and doing it yourself. That was means to maximize the accessibility of the survey for people who both would want to do it online versus in person. We also had an incentive program. So we had all these baskets from donated organizations in town. We had the Red Lodge Mountain. We had the chocolate factory in town. We had all these different kind of nooks and gimmies for a raffle drawing upon completion of the survey. Should people want to sign up for that? So doing this led to the data, and it led to very rich data because we ended up having 155 people who had filled out this survey who had not filled out any of the other surveys that were done in the county prior to. The survey itself had we had 323 respondents in total, which was larger than any or which was comparable or larger to any of the other surveys done. But over half of the people that we reached were people that had not responded to any of those other assessments. So they served as new reaches. Our attempt was to reach as many people as we could. So that was a met objective. That's not to say that everything that we did was then generalizable to the overarching county. That's not what we're saying. We're saying that we're taking steps closer to be more generalizable. Research is an incremental climbing of stairs, and every little centimeter you take gets you further and more closer to your objective. But in public health, we all know that this is a humbling field. We all know that the best objectives we can set are ones that will never truly be attained in our lifetime. That was the first paper I read in my PhD program, and it was the most disheartening yet inspiring piece of literature that I could have read at that point. So anyhow, we ended up getting people all around the county as a result. A lot of times when you do needs assessments or you conduct any assessment in general, you'll often have a disproportionate number of responses in the most populated urban centers that you're at. And yeah, we had 200 people at a Red Lodge, but we had people all across the county. We had 38 people out of Roberts, 30 out of Joliet. We had people in Fromberg and Bridger and Boyd, and Roscoe and Bear Creek. All together, it was about a 60-40 split, Red Lodge versus in the greater Carbon County area, which is a very encouraging sign to be able to reach within the community. Now, some of you may be looking at these numbers and think, well, yeah, they're still really low. Yes, they are. We kept the survey open for a month. Despite a lot of the outreach efforts, it's still going to be very, very difficult to ascertain an entire population. There's 10,000 people. The census had about 10,000 folks are residents of Carbon County. You're not going to get 10,000 people. In research, you take a sample from a population because it's never feasible or even possible to collect information from all 10,000 people. So same reason why I did the National Health or the National Health Interview Survey. That's a survey that reaches 30,000 households annually. It's done out of the CDC. That's federal government money. There's a lot more money attached to that. And even then you get 40,000 people from the survey. That's a big number, but there's 350 million people in the country. So we don't necessarily have to harp on the overall sample size as much as we otherwise frequently do. But you always want to do as much as you can to maximize your sample. And that's what we did. And that's why we had a reasonable cell size outside of Red Lodge. So we are very proud of the success that came with that. We ended up finding that most people heard about us via social media, but our tabling efforts were actually pretty effective as well. The fact that we were in the community and we were able to get word of mouth out there, that ended up yielding a lot of exposure that helped us gain traction of people responding to our surveys. This is to show everyone here that when you are trying to advertise anything for data collection, whether it be an assessment, whether it be a questionnaire for some sort of program that you're rolling out, anything, any data, anything, anytime you're trying to get the word out and advertise, you use social media. Always use social media. It's the day and it's the world we live in now. It should be a standard of practice with everyone if it already isn't already. But use all these other methods too. Tabling. If you can go into the community, do it. If you can print flyers, do it. If you can drop notes at the senior center or people's forms of employment or schools, or use the TV radio, do it. The more mechanisms you use, the more exposure you'll get. And all these individual mechanisms by themselves, I think, are probably by themselves are not as strong, but all together kind of makes your approach much more robust. So I would strongly encourage everyone here who's thinking about any means of data collection in future to use as many methods as possible to getting your word out. And then, of course, the stage 4 is the evaluation. So now we have our data, and now we're making sense of it. We ended up having a total of 323 Carbon County residents complete the survey. Most did it via the online assessment, but 56 completed it via the paper edition. We found that a majority of folks, or the age range was pretty variable. A majority were middle-aged or older. We had about 75, 3 out of every 4 participants were female. A majority white Caucasian, consistent with the demographic distribution of folks in Carbon County. We found that there was variability across people's relationship status, education. A reasonable percentage of folks had some sort of disability, and a large percentage of respondents actually have children, many of whom are of child care age. We had some individuals serving in the military, some with current military active duty status. Majority of individuals also were homeowners and had a direct tie into the community that way. Because we had a lot of older folks respond to our survey, a lot of them were retired, but there was representation across a lot of professional occupation. We found that most folks had either Medicare and or employer-sponsored benefits as their health insurance plans, which is consistent with what we know in the aggregate across national surveys. So these kinds of questions help essentially kind of piecemeal the information that we already know in the aggregate. So that's why it's also helpful to collect information from the census and what is known in a larger scale. We asked people where they typically seek medical care. Obviously, there were a lot of interest taken from the Beartooth Billings Clinic assessment in and around where people utilize their healthcare services or why they aren't going to Beartooth. And we found that a lot of people in Red Lodge will use Beartooth Billings Clinic, but people outside of Red Lodge actually go up to Yellowstone County, go to Billings Clinic or St. Vincent or Riverstone, about an hour north. Now they're geographically closer, but it's interesting to note that there's overlap in where in which people access the care that they seek. So this is data to kind of help point the picture a little bit more. We also asked health indicator questions. Describe your mental health in general when considering stress, anxiety, depression, and emotional problems. We found that a very small percentage of individuals, less than 5%, responded poor to this item, which was inconsistent with other questions that we asked in the survey that asked about people's concerns about mental health in their community. The fact that so few people said that their personal mental health was poor, but their overarching concerns of mental health were high, suggests that perhaps people might have answered this question saying that their mental health was better than it was, which is one of the things that comes with a lot of social science research and a lot of involved questions. Not everyone wants to outwardly admit that their mental health is poor. We also know that there's a great deal of stigma attached to that as well. We asked about substance abuse, found that a large percentage of individuals, close to 35, 40%, have a modest to high level of personal effect in their life, negative effect by either themselves or someone else's substance abuse issues. That stress is highly prevalent. About 3 out of 4 individuals have either a moderate or high level of stress. And about 1 in 4 individuals from the survey indicated that they feel at least occasionally isolated or lonely. We followed up questions that run in tandem with the medically charged questions from the Beartooth Billings Clinic assessment to make sure that we had some sort of metric on people's reasons for delaying medical and or mental health specific care across different domains. We asked questions that the Carbon County Health Department was specifically interested in, on how much people have heard of the following programs that are either currently rolled out or in the process of being rolled out in the area, as well as their interest in programs that are currently being developed or potentially being developed. So a question like this can help you glean the interest on how much a service that you might roll out be utilized. We then created some composite scores, which is done a lot, very frequently, with respect to a lot of health service research. Oftentimes you'll ask a series of questions that are kind of that kind of encapsulate within a certain idea or concept. In this case, we had 7 questions that asked about availability of healthcare services. So then we took those questions and aggregated them into a collective measure that classified participants as either having poor, fair, or good/excellent overall availability of services. And then we took those aggregate scores and examined the degree of their health challenges, their perceived health challenges across those different aggregate measures. In the top left, you can see that 58% of people with poor availability of healthcare services indicated that they have some moderate or great issue with respect to substance abuse. You notice that that percentage decreases with the better a person's level of availability of services is. 43% with fair availability, 28% with good or excellent availability, respectively. So this is kind of showing that there is an aggregate, and the fact that there's a decrease in all of these measures shows that a person's overall availability of healthcare services in Carbon County is positively associated, or sorry, is negatively associated with their degree of health challenges as it relates to substance abuse, mental health, stress, and loneliness isolation. This is taking information that you put on a survey and putting a bit more context to the cross tabulation of the findings, while also being very prudent with how and in what context you present it. We did the same thing for transportation. We did the same thing for affordability of services, finding that the collection of people were either in no issue with affordability, moderate, or major. Same kind of deal. Oh, okay, there we go. We're actually at the end. Perfect timing. We got 10 more minutes. Okay. I wanted to make sure that there was at least a few minutes. Please, okay, so 2 things really quick. Please, if you have questions, go ahead and put them in the chat so we can spend a few minutes here. I appreciate all of you for spending a few minutes ahead of this talk, giving or filling out the survey. I intend to follow up with each of you to respond to some of the things that you inquired about. Again, yes, Kelly, the slides will be shared. Absolutely. I believe Desiree will share those out with everyone. Absolutely. There was, okay, let me make sure I get all the other questions here. Kelly said, or that the survey respondents are concerned about did not participate. Yes. Good point, Kelly. Yeah, there's definitely challenges when it comes to collecting data via survey, when it comes to response bias. That is a whole other piece that we didn't get too detailed into here, but that is always a caveat that you want to acknowledge when presenting your information. The way I was being prudent about presenting this was based on not making anything overly generalizable. So the prudent nature of that communication kind of helps cover your base and make sure that you're not overstating your results. As you're all putting your questions together, I do want to make a note for those of you still on. Thank you for listening. Very much appreciated. Everything I shared in that last 30 minutes, again, was a needs assessment that has now launched into a number of other work projects with Carbon County. We are currently in the process of developing an employer-employee assessment to navigate how to reconstruct the nature of childcare systems in the area, in the county. We're rolling out mental health screenings in the schools. We're in the process of figuring that piece out. We're now going to be pairing work with the Beartooth Bugs Clinic to create a more circular point of examination across health challenges viewed from or experienced out of the hospital and the health department. We all got to work as a team, right? There's a lot of opportunity for us to nullify the silos that we all exist within. I don't think that is a bash to any specific industry. It's the way that the world goes. Team-based approaches are something that naturally and organically come to fruition. So we got to make sure we lean on each other for supported resources, which is another reason why I'm shamelessly telling all of you that I'm here to help you if you feel that there's value that I can provide. Mackenzie, y'all, now data is like data can be like cumbersome, it can be tricky, and honestly, it's actually it can be kind of fun when you bring it all together. When you figure out how data can be used to make actionable translational improvement in a community, it's a pretty rewarding process. And then it ultimately creates this notion of a more positive data-driven approach to the world. The reason why I'm working all those different jobs that I told you about right now, the reason why I'm sitting in my office at MSUB in the liberal arts building teaching an introductory level statistics class to a bunch of undergraduates, is to propel a more positive view and regard and interest and intrigue in and around the application of statistics. Any opportunity that I can have to provide that energy into any industry is very much sought. So I love giving these presentations. I'm very, very thankful to Desiree and the Montana Public Health Training Center for keeping me in the fold for these. Joshua, how often do you find yourself using programming languages for the purposes of data modeling? If you do, what languages do you typically use? Absolutely, Joshua. I use statistical packages. I use SAS and R. R statistical software is free. It's a language that has a community build to it. So there's like the code and all the information exists out there is kind of like a growing archive base of all the knowledge that I have. I've noticed that everyone else who uses it does the same thing. You learn how to do something, and then you kind of put that into a little package on how to on doing that, whether it be for data cleaning or analysis, or as you mentioned, data modeling. I use that quite extensively. So I used to use SAS. I love SAS too. When I was in graduate school, I learned both SAS and R. SAS, however, is not free. It's very expensive, and unless you're with a university that pays for the license, you're forced to kind of find alternative means. So I'm also proficient. But there's also Stata, there's SPSS, there's other statistical packages. I would say that R is becoming the most popular though. And that's the one that I use exclusively now and have for the last several years. You're very welcome, Deb. Thank you so much. You're welcome, Josh. Thank you very much. Thank you all for the questions. Any other questions? As I mentioned to you all, I'm going to follow up via your inquiries that you sent to me via that survey. If you haven't filled out the survey, please do so. I would love to follow up and kind of learn more about your data needs and whatnot. But I will definitely be following up with the individuals who have shared that out, especially for the questions that you've asked and want to learn more about. I'll definitely carve out some time in the next couple of weeks to make sure I give you all the information that you asked me for. Thank you so much, Kelly. I intend to incorporate some additional pieces in January regarding data visualization, and we weren't able to get too deep into the data visualization and the misleading data in this one. So that'll certainly be a plug to have that we incorporate in January. So looking forward to sharing that. Thank you so much.
Well, perfect. Thank you so much, Nick. We just really appreciate you and all of your experience, and always learned so much. So with that, if you haven't had a chance to, please fill out the questionnaire, and we'll let you go for the rest of the day.